So I'm at risk at being a little redundant here, having wonderful talks by Rich and Tim, but I thought what I would do is add a neurological perspective here and talk a little bit about our the way we consider the brain and neurological outcomes and the risks that you heard of, and also listening to Keith's nice talk. I will sprinkle in a little bit of thoughts on modeling. I will warn everybody that I actually have more questions than answers, but I think I'll start with the easy part. And I think that's often forgotten, that the most important determinant in neurological outcome is timing. And the clinical course of cerebral ALD in the active inflammatory form is clearly progressive, and we know that the earlier we treat in this course, the more brain we can preserve, the more function we can preserve, and that these children that are treated at the early time points tend to do better, regardless of whether they get bone marrow transplant or they get ex vivo gene therapy. I will also add that unfortunately we still don't have good treatments for advanced cerebral ALD, right? And when we look at this slide that has been shown often before, really half of these boys are not included in the current label, are not included in the current trials. And I would see an opportunity here, Tim, Rich, right? If we are thinking about new trials, we don't have to necessarily approach only trials for things that have been done before. There's still open questions around the neurology. And are there ways to expand and approach FDA about new trials beyond the current indications and learn as we go? Of course, there are challenges in many different directions here, but I would say having to do trials is not the worst thing. It could open up opportunities for new populations. So thinking about the brain, again, just to set the stage here, we're talking about an expanding lesion, and you heard very nicely from Renee this morning about the various different areas of the brain and tracts involved, and then the zonal pathology with opening of the blood-brain barrier, where some of the devastating aspects of this cerebral disease have also become opportunities, as when the blood-brain barrier opens up, we can get cells from the periphery into the brain, and this has enabled correction of this disease. After residency, traveled to Cleveland Clinic with a trunk full of autopsy material from the University of Maryland, trying to understand and solve some of these questions around cerebral ALD. And what Richard Ranzerhoff at the Cleveland Clinic pointed out to me, that this disease was so different than what they saw in multiple sclerosis, because there was this band of microglial cell death around every lesion that occurred. And that really gave me the conviction that this approach was the right one, which is if we can bring in precursors of those microglia, if we can bring precursors in from the bone marrow, these myeloid cells could help salvage these lesions. And everything our bone marrow transplant colleagues have done for decades has really helped so many families in this path. But us neurologists are really dependent on that path from bone marrow to blood and from blood to brain. And you've seen this slide again, but just to reiterate the fact that while cells are corrected in the periphery, they have to travel now from bone marrow to blood and from blood to brain and become microglial-like cells. Some of the thoughts that are on my mind now is, as we have MDS, as we have hematologic cancers, what is happening to those cells that are now traveling, from bone marrow to blood and blood to brain? And are they still functional? Are they still helping the brain stabilize as we have seen after transplant and ex vivo gene therapy experience? And as Tim said before, 2 steps forward, 1 step back. We are now in a situation where we have to rethink some of the efficacy and in light of some of the safety questions. But I think thinking through this again brings new opportunities. We know that this treatment works, that there is efficacy, that this path from bone marrow to blood and blood to brain is vital and important. For many decades, neurologists were denying the fact that bone marrow transplant really could impact the brain. I think in the field of neurology, this is now dramatically changed after the ex vivo gene therapy reports. Many neurologists and neuroscience as a whole is paying much more attention to these pathways and how myeloid cells can improve and impact the brain. I will just point out that, again, the preponderance of cases having happened in 104 also points to effects of fludarabine versus cyclophosphamide that have been mentioned before, but there are many other factors, as mentioned, vector copying under insertion sites, and the promoter that play a role. The big piece that we've not discussed, and we haven't really had a model system to interrogate, and I think that's why it's so exciting to hear what Keith is doing, is what is the effect of ALD itself upon this whole process? And is there an aspect of very long chain fatty acids, of the ABCD1 mutation itself? And are we thinking about it too narrowly if we're just thinking about it as brain disease? Is there a hematologic preponderance and something that we should consider as a susceptibility there too? I'll just point out that here the majority of the cases, again, as reported in the fall, had unrelated mismatched core donor or haplotransplant. So really no good donor availability, justifying really that they went into gene therapy in the first place. So in the absence of really having large neurological outcome to analyze and report on, what I thought I would do today is report on two different cases of neurological outcome of childhood cerebral ALD after ex vivo gene therapy and myelodysplastic syndrome, to just illustrate the spectrum of what can happen. Here, a case of a 5-year-old boy with XALD with a long-standing history of stuttering, right-sided exophoria, and clumsiness. He converts to childhood cerebral ALD, and you can see here the images on the right, where you have a lesion, classic lesion in the splenium of the corpus callosum paraventricular central, contrast enhancement emerging. This would be equivalent to a less score of 5. He converts to cerebral ALD, enrolls in the ex vivo lentiviral gene therapy, receives busulfan and cyclophosphamide, has no matched sibling, no well-matched unrelated donor. That was the basis for the choice to go into gene therapy. After gene therapy, he's homeschooled. He has limited outdoor activity due to free-range chicken at their house. Follow-up at age 7, he's poorly engaged and distracted, clumsy, remains homebound due to the COVID-19 pandemic. You can see that his clock drawing is quite poor and very fidgety, and poor attention span here in math on copying simple figures. He attends speech therapy once a week. At age 10, he undergoes strabismus surgery. He has repeat complaints of double vision that only half a year later are recognized to be focal seizures, and then has a brief generalized tonic-clonic seizure. At age 13, he has increased fatigue, pallor, weight loss, and petechiae. He's anemic, has platelets drop with peripheral blasts, has bone marrow evaluation 15% blast, admitted for a bone marrow transplant with a 4/6 umbilical cord transplant. His transplant is complicated by septic shock, multi-organ failure, prolonged hospitalization. We often talk about engraftment problems, graft versus host, but we don't talk about many of the other transplant-related complications that can occur. So he's ultimately discharged to rehabilitation due to severe deconditioning. He has a 3-month stay within the rehabilitation center. I'll put here the MRI right at the beginning, right before his transplant. You can see that the lesion has progressed, as we see with many cases, but no contrast enhancement. We would consider this an arrested lesion. Clearly there's some atrophy that has occurred. A second case here now of an 11-year-old male with XALD diagnosed on family screening. He has a normal baseline neurologic exam. He converts to cerebral ALD, enrolls in ex vivo lentiviral gene therapy, receives busulfan and fludarabine conditioning. 18 months later, he develops myelodysplastic syndrome. He receives a bone marrow transplantation, complicated by post-transplant diabetes and adrenal insufficiency. But here is the cerebral ALD lesion before gene therapy, and you can see he has a lesion here within the corticospinal tract that is contrast enhancing. And after gene therapy and the bone marrow transplant that he went through, you see this lesion has completely disappeared. So there is no sign of lesion, and we have a handful of cases like this. And I want to just point out what his neurologic exam looks like, which is he has a beautiful stride, he runs, his tone, he's completely asymptomatic, and he's a stellar student in school and getting ready to go to college. So I illustrated these two cases to show you a little bit the spectrum of what you can see that influence neurological outcome. I think there are things that we really haven't talked about enough, as we are often considering simply, less score and being asymptomatic or symptomatic. Baseline performance at the time of cerebral ALD conversion, I think, is important. There are other factors that can contribute here: comorbidities, developmental delay, repeat procedures, and conditioning regimens are also very of great influence here. We've seen prolonged hospitalizations, deconditioning contributing to neurological outcome. And I would say that treatment modality, gene therapy versus bone marrow transplantation, may be less relevant than baseline characteristics when it comes to the neurological outcome. So what is the IQ coming in, the less score, the symptoms, and also the complications you experience that we don't have a good systematic way of capturing. How myelodysplastic syndrome and its treatment impacts the brain remains unknown. So far, there does not appear to be a change in less score or new contrast enhancement that we've seen. But there are still many things and questions that need to be answered, and I think we need better model systems in order to interrogate this, in order to understand questions that Tim also raised, like what is the right cell type that we need to correct. What is really the functionality of microglial cells or other cells that is occurring? I studied this cell death of microglia in the brain, which is very prominent. But what are the different stages, and what are they reacting to in the brain that is having this propagating cerebral lesion? So I promised you I'd leave you with more questions than answers, and I think I've delivered. So the field is getting more complicated, but I would say overall, because of all the work that Elisa has done in terms of newborn screening, in terms of us coming together as a community to get to early detection, to understand that we need more therapy and treatment options, we can start now finding more individualized therapy, but it requires us going into more detail and not being shy of understanding the importance of individual experiences and the various susceptibilities that might occur, and how there might be interactions of different treatments and different complications as they are influencing outcome. I was listening to Renee's talk, thinking, we really don't understand well how lesion location is also influencing outcome over time, and that is another big factor that we need to bring into this equation. So, relatively short and just on time for probably the most important presentation of a patient later, but glad to take any questions.
Quick question, actually, and I know this talk didn't necessarily touch on it exactly, but you've discussed it before. But when you talk about areas of involvement and things like that. Are you seeing any correlation with pre-transplant and then post-transplant visual and auditory processing issues, and like the areas of injury and how that sort of plays a role? Because I know that's another big thing that is occurring. I'm very into that because of my son's visual processing.
Yeah. So I do think we think the size of the lesion is certainly a contributor, and that the burden of cognitive processing problems increases as the lesion increases. I think a structure-function correlation of lesion location with visual or auditory processing problems has been more difficult than I thought. We've analyzed this more recently in looking at cognitive visual impairment, and have not been able to show a clear correlation between posterior lesions where you might imagine some of the visual optic radiations to be running through those lesions versus the frontal lesions. But I think there's much more work that needs to be done there, and so that we can understand it in more detail. I do think that different lesions are moving at different speed, and they are also responsive to treatment in different ways.